So welcome, and thank you, Dr. Stephen Glazer, who's joining us from Canada for this interview. My name is Dr. Carlos Nunez. I'm the Chief Medical Officer at ResMed, and really excited to be speaking to Dr. Glazer today. Dr. Glazer is the current president of the Canadian Association of Bariatric Physicians and Surgeons, and a renowned sleep medicine specialist with expertise in treating sleep disorders such as sleep apnea. And it is such a pleasure to have you for this conversation. Dr. Glazer, why don't we just start off by you giving us a little bit of your background? Tell us how you came to specialize in both bariatric and sleep medicine.
Well, thank you. And thank you for the warm introduction and the opportunity. So I'm a board certified internist and critical care medicine specialist. And I started off many years ago, unfortunately, and as a general internist, and had a great interest in perioperative risk management. And through that, I became exposed to, first off, sleep medicine, and went on further to be specialized in sleep disorder breathing and medicine. And then our hospital became a center of excellence for obesity, where I developed a comprehensive, both surgical and medical program. And it all makes sense, internal medicine, sleep medicine, obesity medicine, they all sort of commingle. And so it's provided me with a very interesting opportunity to help people living with obesity and people living with overweight. And it's been an amazing ride as that field has become more and more developed and established.
Well, we share two things in common, both an interest in perioperative risk. I'm an anesthesiologist and critical care physician by training, and we're both intensivists or critical care specialists. And yeah, it's true. You see in the ICU so much of the comorbidities that play into perioperative morbidity and mortality. And it's a fascinating intersection of where so much that can go wrong in physiology and in medicine kind of meet. So I can see why that would be a very fulfilling and interesting journey for you. So today we would love to talk about a topic that intersects both of those interests you have in both bariatric medicine and sleep medicine. And it's the recent results that came to light through a press release. So we don't have the full scientific study yet to look at, but of the Surmount-OSA study, really sort of two studies within one that aim to compare the efficacy and safety of tirzepatide, a dual incretin-type drug, a GLP-1 and GIP receptor agonist. And the participants all had moderate to severe sleep apnea and comorbid obesity, but they did not have diabetes, which was the first and most common indication for these drugs. Versus placebo was the study design. So break down what you saw in those findings, what you saw in the press release, and how that relates to both obesity and obstructive sleep apnea.
Gladly. So this is actually quite a fascinating study, and for the most part fairly novel, because you wouldn't intuitively think that you'd have a large-scale study of this magnitude addressing both these issues concurrently. So it is a 52-week trial of tirzepatide versus placebo, and with individuals BMI of 30, so class 1 obesity, about 469 individuals, half of which had sleep apnea but weren't being treated, and those that were being treated subjected to either placebo or tirzepatide. These were moderately to severe individuals living with obesity, and they were treated with a standard dose of tirzepatide up to 15 milligrams, and outcomes were measured with respect to its safety and efficacy with respect to weight loss, and also what was the effect on sleep apnea. In addition to that, there were other secondary measures that looked at physiologic or metabolic consequences, functional capacity, quality of life, other cardiometabolic issues. And it's incredibly exciting, at least the preliminary results. And we don't have access to all the results, but for those individuals that had sleep apnea but were not treated with CPAP, there was a significant reduction in AHI, about 55%, resulting in an AHI approximately decreasing from 50 down to 27, as well as about an 18% weight reduction, which is what we typically have seen in our previous studies, compared with placebo, where there was about a 5% reduction in AHI and a 1.3% reduction in weight. And then when we look at the individuals in the group that were on CPAP, similarly, there was a decrease in AHI by about 62%, with an AHI from 50 down to approximately 30, and a 20% reduction in weight compared to placebo, where it was an AHI reduction of about 6.4%, with a 2.3% reduction in weight. So in both groups, there's quite fascinating and exciting results that many of us can't wait to sort of delve into all the minutiae of the results. And as well, secondary outcomes were also favorable. For example, the improvement in systolic blood pressure or markers of inflammation. And it really ties in, the pathophysiology of obesity and sleep apnea and inflammation and the significance of weight. So, the results are quite exciting and will be clinically useful.
Yeah, it is an exciting trial. And as we've known for decades, really, an important part of treating sleep apnea is weight management in those who are dealing with excess weight or obesity. And so if this proves to be another effective way for the weight management part of that treatment to happen, then it bodes well, because as you said, these patients still have sleep apnea. It lowers their AHI, but it's still moderate sleep apnea. But it might be easier to manage their sleep apnea, lower pressures, or easier for them to tolerate therapy. And as promising as these results may be, we obviously have to interpret them carefully. They came through a press release from a company, not a peer-reviewed journal article in a scientific journal. That is forthcoming. We know that they are planning to present the results of this study in June at the American Diabetes Association conference, and we assume that whatever journal will publish this study probably happens around that time. But we also want to make sure, looking at these results in this press release, is it possible that there are things that might be misinterpreted or not interpreted as clearly? So are there things to look out for, things in the press release that caused you maybe some pause?
Well, you've highlighted several very important points. First of all, and we get this often even with individuals undergoing bariatric surgery, that they lose some weight and they feel that they no longer need to use their CPAP machine, which is absolutely, counterproductive for these individuals. So the first point, I think that you pointed out, that despite the fact that we're treating moderate to severe individuals with sleep apnea after the 52 weeks, they still may require ongoing therapy. And so, as I tell my patients often, the absence of snoring is not synonymous with resolution of sleep apnea. I get that all the time, and it leads our patients in wrong direction. So that's the first important point that you mentioned, and I concur. Also, that this is a study of a select group of individuals. It's moderate to severe. It may or may not be generalizable, and so we have to keep that under consideration. This trial wasn't designed to compare therapies or demonstrate efficacy of GLP-1s used in combination with CPAP therapy. So we have to make sure that we're aware of what was the objective of the study and make sure that we take that information and use it in a responsible way. I do note that many or the individuals that did have CPAP were given a washout period. I think that's a favorable and powerful aspect of the study, trying to sort of disentangle the effect of CPAP and weight loss. So I think that's another very important point. The study is not meant to, have a cure or even to replace CPAP therapy, so it shouldn't be misinterpreted from that point of view. In addition, it's early. I mean, we're embarking on a new sort of territory. It'd be interesting even to explore, is there any physiologic, biologic utilization of GLP-1s in the actual treatment of sleep apnea, aside from weight reduction in of itself. And so we have to be careful that we don't make, very broad generalizations, and that we examine the data as it becomes available for us.
Yeah, no, I couldn't agree more. And it is a fascinating study. It seems to be well constructed, but we really do want to see what the results in the peer-reviewed publication show. And, like any other clinical trial, I'd love to remind people that are going to hear this interview that, a randomized controlled trial, that middle word controlled is really important, because everything is controlled down to one variable if possible, or as few variables as possible, because that's what you're trying to really test. And these are patients who were monitored closely, were also, even in the placebo arm, offered things like diet and exercise counseling to make sure that this weight loss journey was not, was optimal. They wanted, so at the end of this 52-week trial, they got these patients to the best, situation they could be in. That is not the real world. In the real world, drugs are taken differently, people follow instructions differently, and they don't have, a clinical trial study nurse calling them every week to make sure, are you taking your drugs? Are you filling out your log? Are you coming next week for your follow-up? It's a very controlled environment. What do you expect to see in the real world, or what are the challenges in the real world we need to think about that may not, that we'll have to think about as we apply the results of this trial in clinical practice?
Well, I just want to take a step back and emphasize something that when we do our teachings of other healthcare professionals, and similarly what we want to transfer knowledge to our patient, is two important points that you said, and I want to re-highlight. All weight loss trials, inherent in good trials, is exercise and dietary restriction. And so while we focus less so on diets and more so on medical nutritional therapy, as per our Canadian guidelines that we published in 2019, it's very important that this trial had a deficit of calories of about 500 calories per day, and also 150 minutes of exercise. So we should never be lulled into the thought that we take a medication and we're going to get effects. There has to be a commitment. So that's very important. The other things that we're seeing even in many of our weight loss trials is there are limitations in the real world that don't get the results that we get in trials. Trial patients always do better for the issues that you talked about, but in the real world there are realities. So as recent as access to medications, there have been worldwide shortages of medication, which has been very problematic for healthcare professionals and for patients. And there's been a roller coaster of availability and changing and rechanging, and so that's been very problematic. The other thing that I want to sort of say and be a little bit tangential is understanding that obesity is a chronic, relapsing, unrelenting disease. It's a disease. It's been categorized as a disease by many associations worldwide. And so we have to continue to address this as a disease. And as a result, individuals will need chronic therapy. And that may include medications. And from that, the point I wanted to make is that funding for medications remains a big hurdle to overcome. To some extent, it can even be discriminatory for the haves and the have-nots. So we need to ensure that there is funding available for the management of people living with overweight and obesity, and that financial constraints don't limit optimal therapy for individuals. So those are, some very real things. The other thing that we see over and over again, this was a 52-week trial. And often weight regain is a very, very real phenomenon. And so while it's great for the 52 weeks, and often we get the question, well, doctor, how long can I stay on this medication? To which I answer, a long time. But we have to understand that this is just the tip of the iceberg, because obesity is a chronic disease. That's why I want to emphasize that. And so we don't only have to worry about this 52-week period, but often weight regain is a feature that we see and we have to contend with. And that weight regain results in reemergence of comorbidities. And so we need to be cognizant of that.
Yeah, it's a really good point to make, because it's not just that these trials are so idealized in their construction that these patients do better. There are things that, weight regain when you stop taking the drug, or other considerations. For example, it may take a year, or some of these trials looking at cardiovascular effects, 2 years before the patients reached optimal weight gain. And one thing that both obesity and sleep apnea share is that both of these conditions often live in the dark. Patients, for two primary reasons. Obesity, there's a lot of shame still, even in the medical community, and a feeling that this is your fault and there's nothing you can do. For sleep apnea, it's a lot of just no knowledge of the fact that, maybe you don't snore, or you snore, but you're asleep and you don't hear that you also stop breathing. And so we are going to see patients come out of the dark and go to see their doctor because they're going to hear about these new drugs. They're going to say, you know what, maybe it is not my fault. It is a disease and there's something to do about obesity because I'm hearing about these drugs. For these individuals motivated to seek treatment, who may not know they have sleep apnea, or they're dealing with cardiovascular disease or diabetes or whatever, how would you counsel them or offer them advice when you go to talk to your doctor because you finally want to seek some help for your weight about those other comorbidities, especially sleep apnea?
Well, those are excellent points. And so first off, I'd like to highlight a weight bias and stigma. So in the Canadian Medical Journal, we published the Adult Canadian Guidelines. And there's a particular reason why the first chapter of the guidelines focuses on weight bias and stigma, because both weight bias and stigma have a significant impact on individuals and outcomes for those individuals. For example, one of the reasons, or one of the hypotheses why people living with obesity had a bad outcome, a worse outcome from COVID, was because some individuals presented late to their physicians because of their negative experiences in the past. So we cannot minimize weight bias and weight stigma. The other thing I want to highlight is that as we're emerging out of COVID, we cannot sort of ignore the effects of COVID-19 on people living with obesity. Myself and Dr. Michael Ballas did a national survey of the effect of COVID-19 on people living with overweight and obesity. And it was a very large study. It's called the EPIC study, which was the evaluation of the pandemic on obesity care and health. We found many things. So the first paper we published was vaccine hesitancy. So you would think that of the one group of individuals who wanted to get treatment to protect them would be people living with obesity. And in fact, attitudes to get vaccination were actually less in people living with obesity. And it may be due to stigma and bias. But also, in our second paper, we looked at the effect of weight gain, and there was about a 60% weight gain of individuals living with obesity during COVID. So weight is a huge factor. Not only that, there are changes in healthy eating and exercise and food consumption. And so you can see how all of this interplays in the care of individuals. So getting back to your question, so what are the things that we really want to encourage our patients? Well, we want to encourage that open discussion about symptomatology. We want to educate the patient that they can advocate for themselves about the symptoms, and in healthcare professionals, because, for example, women and men present differently for sleep apnea. Their symptoms are different, so we have to be on the lookout for people. We published a paper several years ago on screening questionnaires for bariatric surgical patients presenting for bariatric surgery. And we checked, we validated both the Stop Bang questionnaire and the Berlin questionnaire. And we found that individuals presenting with bariatric surgery, first off, the screening questionnaires for that population were not reliable, sensitive enough to detect sleep apnea. But more importantly, that almost 50%, 48% to be precise, of bariatric surgical patients coming for bariatric surgery, the one population you would think would know about or be identified and treated for sleep apnea, 48% of people who came for bariatric surgery had moderate to severe sleep apnea without even asking a single question, just subjecting them to a sleep study. So both healthcare professionals and our patients need to be aware about sleep apnea. And I think that in my experience, it's probably the most common unaddressed medical condition. So that's the first thing. I think it's very important to understand that, obesity and sleep commingle. That's why it's so fascinating for me to deal with both of them concurrently. And so when you have a patient who's living with obesity, you got to think about sleep. And when you have patients that have sleep disordered breathing, you have to at least evaluate their status and then work collaboratively, not only with your patient, but also the family and other healthcare professionals.
Yeah, thank you. No, and it's a really, really important point about, other healthcare professionals besides sleep medicine specialists or obesity specialists. Too often, and you know this from your time in the ICU and in perioperative medicine, too often a person is first diagnosed with sleep apnea because they're getting some other medical procedure done, and it's uncovered there. Like you said, people showing up to get bariatric surgery, you would have thought somewhere along this journey, long before they presented for bariatric surgery, one of our colleagues would have asked the questions to get them diagnosed with sleep apnea, because we know how much they commingle. It is interesting. You mentioned it's one of the diseases, if not the one that you see, we kind of miss the most. If the numbers that the literature show are correct, there's about 1 billion people, billion with a B, that have this condition, have sleep apnea, but 80+% are undiagnosed and untreated. And so hopefully, helping other physicians beyond physicians who specialize in sleep medicine understand, as these patients start to show up and ask more about these drugs, what would you tell primary care physicians or, internal medicine specialists such as yourself who didn't specialize in sleep?
Yeah, I think that, you have to think about the condition in order to at least, try to treat the tip of the iceberg and beyond. You're absolutely right. The majority of people living with sleep disorder breathing are not addressed. And similarly, when you look at other chronic conditions like diabetes or hypertension, many of those patients are treated with pharmacologic agents. In distinction with people living with obesity, where pharmacology is a small proportion of the therapy that we implement for people living with overweight or obesity. So I think that we approach obesity, I'll talk about obesity first, in a pillared approach. And we address both the psychology of obesity, pharmacology, and their approaches for the treatment of obesity, and the surgical approaches. And so we need to understand that it's not one or the other. Sometimes it's a combination, and so we need to educate our healthcare professionals and our patients that there are options there, and options of pharmacology or surgery, for that matter, are not an example of failure. We don't get bariatric surgery because we failed all else. We get bariatric surgery because it's the most efficacious treatment based on the evaluation for an individual, if that is the case. It's not always the case. And similarly, for a sleep disorder breathing, have a high level of suspicion, because we do know that sleep apnea is associated with other comorbidities, increased mortality, cardiovascular outcomes, metabolic outcomes, quality of life outcomes, productivity, mood, motor vehicle accidents, just to name a few. And so we really need to approach our patient holistically from top to bottom, and address all these issues. I think that we need to, as I said, to collaborate with other specialties, primary care, sleep specialists, internists, surgeons, and allied health. I can't underestimate and underscore the importance of our allied healthcare professionals, who are so integral to the management of people living with obesity and even with sleep apnea, because they play a very crucial role. So I wanted to throw that in as a very important point as well.
Yeah, no, I couldn't agree more. When you think about anyone in the optimal health that we all seek, the 3, maybe 4 pillars of this health: sleep, it's what we eat, and how we move our bodies, and then how we recover and manage stress. Some people say is the 4th pillar. And we often neglect our sleep, but it's that frontline healthcare provider, that allied health worker often, that sees the person first, who can ask that question about sleep or daytime somnolence, that might help prevent an automobile accident that very day, or a heart attack 10 or 20 years down the road. So,
and even further to that, as we explore and we're understanding obesity and sleep apnea, our sleep disorder breathing, further, I want to introduce the other notion of cognitive function. We talk about diabetes as type 3 or diabetes and dementia. We talk about the morphologic changes on MRIs with people who have sleep disorder breathing. We talk about executive function abnormalities in people living with obesity and attention deficit disorders. And it's interesting, if you look at it, sleep and obesity have so much in common, even from a cognitive point of view. If you don't sleep, you don't exercise. If you don't exercise, you can't be productive and have the energy to deal with what you're faced with during your day. And so we can also sort of underestimate the effect of both those chronic conditions on cognitive function as well.
Yeah, it's really important, because it's often difficult for a person to think about something that's going to happen 20 or 30 years from now when making decisions about their health. But the thing that probably would scare me the most anyway, is when you think about that cognitive function, because we are seeing more and more evidence that, obesity and sleep disordered breathing increase the risk for things like dementia later in life. And that, is, I think for most people, is a very, very scary prospect of an outcome. So hopefully, again, with all of this attention on obesity that these drugs have brought about, people will start to seek care. They'll go to the doctor, and any good physician is going to work up the entire patient. And if you have diabetes, sleep apnea, cardiovascular disease, you'll also get care for those things. People deserve the therapy for and the care that that they need for these diseases and conditions that we have. And like you said, addressing things like disparities and making sure we put the attention on the right things. And yes, press releases are nice, but it'll be great when we get to see the data and make better sense of all this. So I really want to thank you, Dr. Glazer. This has been a really fun and interesting interview. You had great insights, and I would love to talk to you again if the occasion ever presents itself.
Look forward to it. Thank you very much for having me today.